TNT Open Mind Insights brings you powerful, authentic conversations, illuminating the path to better mental health care for all.
I'm happy to be here with Dr. Melissa Wagner. I've had the good fortune of getting to know you a little bit in bits
Yeah.
and pieces through the TNT program. I, I'm going to guess around over the last 2+ years. Uh, I'm really excited today to really go to a little bit deeper level of understanding the work that you do, how you came into that work, and more depth to the importance of what you do. So I'll call you Melissa. So, Melissa, maybe begin to share what is most important to you in the work that you do that's so important in providing care.
Yeah, thanks, Rimal. So I'll give a little, I don't even know if you know this, but a little history. So I did both an MD and PhD, and I joke that I was permanently indecisive. And throughout that, I had thought about doing a residency during training in pediatrics, thought about doing one in psychiatry, and thought about OB-GYN. And during my exploration at the end of medical school, I was like, okay, I'm going to do child and adolescent psychiatry. And then I had a friend who was a resident at Riley, which is the children's hospital associated with Indiana University in Indianapolis. And she was, have you heard of this thing called the triple board program? And I was like, no. So let's extend my training longer.
All right.
like, but so I looked into it, and triple board is training in general
Mhm.
psychiatry, child and adolescent psychiatry, and pediatrics. So this indecisiveness that I had, well, I could kind of eliminate some of that if I did this program. So I applied to triple board programs and then matched at Cincinnati Children's and the University of Cincinnati, which is where I practice now.
Where were you in that medical school journey? Was this toward the end, like
Toward the end,
yeah,
yeah, I had been clinically, so my research was in neuroscience, but
right.
clinically, like really undecided,
Okay.
and like fell in love with clinical medicine in all of its parts. And so that's why I was having such a hard time deciding. Like I was like,
Yeah.
I don't know, I want to still do pediatrics, but I love psychiatry, and where can I blend the two? And found triple board. But I'd always had this, a OBGYN had, it was really like those early bonding moments that I fell in love with, but didn't really know how to incorporate. And actually, throughout residency, I didn't even know if I was going to blend all of these different specialties together. And it was when I took my first job, which was at the
Okay.
University of Illinois Chicago. It was a women's mental health position, and the chair interviewed me, and he said, our women's mental health doc is moving to a new position on the East Coast. We think your background would be perfect. And I just took a leap of faith. And then I found reproductive psychiatry and fell in love with it. And it was truly the blend of pediatrics, kind of women's health, child and adolescent psychiatry,
Mhm.
and adult psychiatry. And I tell when I'm talking to people
Okay.
that I am really practicing as a penultimate child and adolescent
Mhm.
psychiatry because I'm trying to intervene, often with moms, but also dads at
Yeah.
this critical time period where their mental health is very important so we can help the family, the bond, and the next generation.
Yeah.
So,
I always love to talk to people as you just shared that story. You feel I feel it was the perfect fit for you. I mean,
yes, I think
everything
so
just
now, but I
molded.
had no idea.
We always strive for that. Like, what's I feel we sometimes overuse words like passion and I found my calling, but just in 2 or 3 minutes, I felt that you
Oh, yeah.
everything just fit the puzzle, all 100 pieces. Like, there's no missing piece in that puzzle. You found it, and you
Yeah.
that last piece just boom, and you found it early.
I found
I
it.
mean,
Yeah, it was my first
right, your
job, and
first job.
I was like, "How did I
Yeah.
not know this existed?"
Wow.
I
My.
I think if someone had told
Yeah.
me 5 years earlier that this, but
Yeah.
it's the beauty of the journey that led
Yeah.
me there that I
Right.
think really made me appreciate um,
Yeah.
the field. And reproductive psychiatry is it's it's getting more and more recognition,
Right.
but it's so important. So if people don't know, I don't know if you know,
Yeah.
but maternal mental health,
Yeah.
it's the number one morbidity. So
Mhm.
after childbirth. So either depression, anxiety, other mood
Okay.
disorders. So the number one cause of
Yeah.
morbidity after childbirth is maternal mental
Could
health.
you describe again what is, as an expert, your definition of like reproductive psychiatry, reproductive
Yeah.
mental, like what are there clear delineated periods
It's a,
that refers to?
yeah, it's a great
Yeah.
question. So reproductive psychiatry, I would say we really were born out of that perinatal period.
Okay.
So like pregnant moms and postpartum moms
Hmm.
is how we started, but we really want to and have grown that we really need to understand how hormones
Okay.
impact mental health more globally.
Okay.
So even though many of us who practice reproductive psychiatry have always and we still remain dedicated to that time period, we also focus on, when uh, young people go through puberty
Right.
and then that other hormone transition
Hmm.
later in life.
Yeah.
So when we go through perimenopause, menopause, that is also very impactful on mental health. And so when I talk about reproductive psychiatry, I'm talking about hormones throughout that time period.
Okay.
But what initially drew me to the field
Hmm.
was that perinatal period. So those pregnant moms and that postpartum period. And mental health is not, it doesn't go
Right.
away just because
Right.
you're pregnant. It doesn't go away
Sure.
because you became a parent. And so we often talk about the moms or the women that are
Mhm.
affected, but it also impacts dads as well,
Right.
because it's just a huge time of change in life. And so that is really, like, I would say reproductive psychiatry was born, but we really do that
Yeah.
the whole age span.
And somehow I heard the connection of hormonal changes play a role in defining the scope of reproductive psychiatry. Is that correct to some degree? The
Yeah.
hormonal changes, puberty, in when one's pregnant, postpartum. I mean,
Menopause,
menopause.
yeah. So
Yeah.
hormonal changes are huge, and so if we look at data of when mood and anxiety disorders
Mhm.
really change amongst the two sexes. So if you're looking just at kids when they're growing up, depression, anxiety, learning disabilities,
Mhm.
they generally happen at the same, it's like a 1-to-1
Yeah.
ratio male to female. And then puberty hits and things really change.
Okay.
And so those hormones do have an impact on the incidence of both depression and anxiety, where it does increase in women.
Okay.
There's other, big times of huge hormonal fluctuations, which also impact,
Mhm.
again, primarily women, which is during the perinatal period and the postpartum period.
Okay.
So big hormone fluctuations can significantly impact your mood and your anxiety. And then there's another time of
Right.
change, which is menopause. And so during menopause, your brain can be at risk
Mhm.
for so estrogen is actually
Yeah.
can be protective,
Sure.
especially when it comes to moving beyond mood and anxiety. When it comes to psychosis,
Right.
estrogen is protective. So what we see during menopause, two things. So the rates of depression and anxiety after the menopausal
Yeah.
transition go back to being equal between men and women, but there's this risk during that perimenopausal transition where women can actually develop a severe mental illness and that risk uh, does not happen in men. So that losing
Mhm.
actually that estrogen, your brain is again at risk. So it's called late onset
Okay.
schizophrenia or late onset bipolar disorder, and it really only happens
Okay.
in the
So you're
yeah,
seeing people at all those
all
different
ages.
stages. They're coming to you,
Yes.
the referrals. You've been, clearly identified. You're an expert, and people are bringing pe- uh, mothers, women who are having challenges
Yes.
during those periods. As you were talking about that, and I keep coming back to that word hormonal. What about today with all the technology like in vitro fertilization and all, you know, and I think of that, that's involving wanting to get pregnant. Maybe there's not a hormonal impact at that, but that woman, that couple that are struggling to get pregnant and the challenges of that, does that come under reproductive?
It does
Psych
come under
Yeah,
reproductive
psychiatry.
psychiatry.
Yeah.
So there's, especially like my therapy colleagues
Okay.
who specialize really in that, those families that want to conceive and aren't able
Right.
to, those families that have had early pregnancy loss.
Right.
That is an important part of our field as well.
Hmm.
And yeah, again, it's not necessarily influenced by hormones, although we do know those women
Yeah.
who are going through
Yeah.
different procedures are often on, we are manipulating their hormones to help them achieve the family that they want. And that can also impact their mood, their anxiety. And so
Right.
it does fall within our
Yeah.
field as well.
As you said earlier, this is the second most prevalent, like, morbidity.
Oh, it's the
Yeah.
most.
Or the most.
Yeah.
Okay.
So you would
If
be,
you look at the all of mental
yeah.
health, mental illness, this is the
So let me clarify.
yeah.
So in the world of, when we're looking at maternal morbidity and mortality,
Okay.
hot topic.
Yeah.
When we think about, pregnancy-induced hypertension, gestational diabetes, eclampsia, all
Mhm.
things that are very important to screen for and to treat. And my OB-GYN colleagues have done a great job at addressing those
Mhm.
morbidities. What is now the highest morbidity is perinatal mood and anxiety disorders.
Okay.
So during pregnancy and the postpartum period, the thing that women are most at risk of suffering from is a mood and anxiety disorder.
Okay.
And I think if you would ask probably
Yeah.
most, just like on the
Yeah.
street,
Right.
people would think, "Oh no, it's that diabetes. Why do I
Yeah.
have to drink that gross orange
Yeah.
drink at
Right.
like?"
Right.
And during my third trimester,
Yeah.
late
Yeah.
second trimester, right, to
Right.
be tested for gestational diabetes.
Yeah.
Yeah, and the number one is perinatal mood and anxiety
Yeah.
disorders.
So you're clearly so thankful that there's almost a specialty now that
Yes.
just identifies that. And it really started probably when you
Yeah.
entered it, right around that
Yeah,
time.
yeah. So it started, one of the very first programs of women's mental health
Hmm.
was started where I happened to get my first attending job at
Okay.
the University of Illinois.
Yeah.
Started in 1997.
Okay.
Yeah, and then it's just grown from there, and it's getting increasing, the importance of this field is getting
Right.
increasing recognition.
Hmm.
The breadth of the field, as you had asked earlier. So we again started focusing on that perinatal period and
Hmm.
have grown
Hmm.
to really encompass the lifespan of hormone
Right.
changes. And we are now expanding. There's women's mental health and reproductive psychiatry fellowships.
Oh,
We are forming a national board of reproductive psychiatry to help support this work and support expanding fellowship opportunities so that other psychiatrists can join this
right.
workforce and do this
Yeah.
important work.
I'm sure with your commitment and passion, there's always a hope. We need to move faster. We need to
Yes.
expand. We need to go global with this education. But in that short 25 years, I mean, where things were 1997 when you started working to where we are today, are you excited about the movement?
Yeah, so I didn't start. So Laura Miller started.
Okay,
It
yeah,
started in
right,
1997.
right.
I started 20 years
20, yeah,
later.
right.
Um, but I would say, yeah, I mean, even just the last, I've been an attending psychiatrist for 8 years.
Okay,
It's been a dramatic change, increase, enthusiasm, and I'm really excited about our next chapter. Really excited about the National Board of Reproductive Psychiatry and what the future holds. And I think we can make big strides
hmm,
in maternal morbidity and mortality, and just recognizing that this is something that we all need to be aware of. And there's things that we can do to help address it. So if these women are uh, identified and feel comfortable coming forward, there's services that we can offer
okay.
them.
When we think of mental health as a whole and mental illness, the word stigma
Yeah.
often gets associated, appropriately so. But do you feel reproductive mental health psychiatry, maybe stigma hasn't had as much impact that societies maybe versus, let's say, schizophrenia or drug
Yeah.
abuse or homelessness? It's a different type of stigma, how society looks at it.
Yeah, I think that's true, but I think we in our field are always careful, right? There's this stigma of we don't want to stigmatize hormone changes. Like most women
No.
have hormone fluctuations and they don't have a significant impact on their mood, while recognizing that there's a subset that do,
Mhm.
and there's a subset that have a serious impact on their on on mood and anxiety disorders. The other, I think, part about stigma
Yeah.
that's really important is that young parents, there's still this fear that if they say that they need help,
Mhm.
that that is going to label them as a bad parent.
Right.
That is something that I think we have to constantly be mindful of. And so it's different than the
Yeah.
stigma of schizophrenia, but it still
Yeah.
needs to be uh, thought of. And we have to make sure that families, moms, young dads, that they feel comfortable saying like I'm struggling with this
Right.
newborn. I'm struggling with this 1 year old, this 2 year old. I need help.
Okay.
And it doesn't mean that when you say I need help, that doesn't mean that you are a bad parent.
Mhm.
Yeah, it really takes support, a community.
Right. How has general obstetrics, gynecology, approached and felt comfortable that you know implementing just inquiry and evaluation of mental health in their practices.
Yeah, I think they, from a provider
Mhm.
perspective,
Mhm.
they have, they've always welcomed our partnership.
Mhm.
There are so many initiatives across the country really working on. So ACOG recommends
Right.
that they screen
Sure.
for depression during pregnancy and during the postpartum follow-up visit. And I know every
Yeah.
OB-GYN that I know wants to do that. And so
Right.
there's so many initiatives across the country
Yeah.
to make that happen.
Right.
And I would really like there's lots of quality
Yeah.
improvement projects about it, and I think they've welcomed us, many states, to like help kind of address that gap,
Right.
have developed perinatal access lines, which is
Okay.
so the OB-GYNs can feel comfortable. Like, hey,
Yeah.
I now screen a patient, and
Uh-huh.
what if they say, I need help? And then the
Okay.
OB is like, I'm not a psychiatrist or I'm
Right.
not a therapist. What do I do with that? Well, there's perinatal access lines in
Right.
25 states where they can call and get some kind of advice, guidance, referrals for those pregnant moms, those postpartum moms, of where they can go and get psychiatric assistance.
Yeah. As you were talking about its acceptance, the American College of Obstetrics and Gynecology, and their appreciation of the morbidity and it's real. What was coming up in my mind, when a woman that's pregnant or planning pregnancy, we always focus on, are you taking your prenatal vitamins, your weight, vital signs, girth, ultrasounds. This is almost as important. And in my mind, I'm almost thinking if you could have one or the other, a regular mental health evaluation and or let's say partial compliance of prenatal vitamins, this may be of more value to the well-being of the mother and
Yeah.
the future
Well, I
child.
don't want to discount the
No,
folic
no,
acid.
I was just
Just-
no, no, yeah. But I mean, this is right there.
It's
I
right
mean,
there.
it's not like, oh, you got to do A.
Let's
I
not
mean,
get rid of folic
yeah,
acid.
right, right, right. But it's like again, I'm using strong. It's like a no-brainer.
It's like a
I mean, yeah,
no-brainer.
you walk in. If you don't ask that, it's almost like you
Yeah.
didn't take the folic acid.
Yes. No, it's like, yeah.
Right.
Yeah. Yeah.
Yeah.
Prenatal vitamin and screening for perinatal mood disorders. Yeah.
Yeah.
They should be like hand in hand. And for the states that don't have their own perinatal access line, Postpartum Support International
Mhm.
also has has support programs. So providers, who might feel like at a loss and they don't want to broach this subject, there is like support out there for them, and it really should go in hand with that prenatal vitamin.
Okay. And one last question on this area. You mentioned international. We have a lot of, access to high level, or so we think sometimes in the United States,
Yes.
technologies and ways to evaluate outcomes. How are you bringing this work to the world? I mean, how is the world looking at reproductive mental health and psychiatry? Are you even in underserved areas um, that don't have anywhere near the the prenatal care? I mean, how is it being accepted around the world?
Yeah, I think the recognition of how common perinatal mood and anxiety disorders are is widely recognized worldwide. And there are like less technological treatments, which is really like family and community support. Because even if a woman is suffering from, especially postpartum depression, and and I recognize this as I say it,
Yeah.
way easier said than done, but one of the number one treatments is sleep and
Yeah.
rest, right? So support, like having either a partner, extended family,
Right.
sisters, friends, brothers that can help
Okay.
the new mom usually, but new parents in general get rest. That can be a treatment and mitigate the risk for perinatal mood and anxiety disorders, and that has
Right.
that's cheap.
So, do you think if the two of us could like just be transported right now to a small village in Kenya or India, and the person that's sort of following a woman that's pregnant, would that, you know, it- it's not necessarily midwife, but whatever the service the professionals call, would they recognize it in that 9 months? Maybe they had inquired, "How are you
How are you
doing?"
doing? I think it can be that simple, like,
Yeah.
how are you doing? And then
Okay.
in the postpartum period, um, really just acknowledging that it's hard
Hmm. Okay.
and that it's okay if you ask for help,
Yeah.
and then it's normal
Right.
for it to be hard. I feel like we often forget those that are like able to be parents or are
Okay.
parents. We forget those early few months where, like, I remember, like, there's times where you just feel desperate
Right.
and you just don't know. And it would be, just like you said, like a peer support person
Yeah.
in the community that says to you,
Yeah.
"Are you okay?" So that the person doesn't have to say it themselves. So
Yeah.
that new mom can be like, you
Okay.
know, I'm not,
Yeah.
I'm not
So you
okay.
wouldn't necessarily be surprised if we get transported to that small village where there's no hospital for hundreds of miles, that there's a recognition that a mother's mood can change, and the only way you'll find out is if you inquire.
Inquire about it. Yeah, I would
Yeah.
not be surprised at
You
all.
wouldn't be, that's wonderful.
Yeah.
And look, again, 19, I go back to 1997. I
Yes.
mean, the world, it's like, every corner of the world has a acceptance to some degree.
Yes.
That's remarkable.
Yeah.
Um,
Yeah.
you do more than just reproductive
Psychiatry.
psychiatry. I understand in the incarcerated world, women um, may not have the same treatment,
The same.
and that's maybe stigma might be a fit there.
Yeah.
That woman doesn't deserve,
So I think it
this.
goes to like
Yeah,
serious mental illness. So
yeah,
women with serious mental illness get pregnant, you
yeah.
know, and they often interact with different legal systems, different scenarios. So they can be, hospitalized throughout their pregnancy.
Mhm,
They can even be sometimes if during an episode of severe untreated mental
mhm,
illness, maybe have committed a crime.
mhm,
They can sometimes be incarcerated during the pregnancy. And it's going back to go to the question about stigma. I think the stigma of serious mental illness, transcends all
mhm.
populations. And so pregnant women with serious mental illness face that same stigma. But it's so important to still treat them with dignity and do what we can to help ensure that they're safe during the pregnancy, that the fetus is safe, that during the time of as best you can get them stable so that they can engage in a conversation of what they would like to have happen.
Mhm.
Our my goal with someone with
Yeah.
serious mental illness that's pregnant is to always get their symptoms under control before they deliver so they can participate, you know, to the
Mhm.
ability that they are able to in a conversation about, if they're not going to, let's say they have severe
Right.
schizophrenia, if they're not going to be able to parent, can we at least engage them in a conversation of who would they like to have parent?
Mhm.
Do they want to place the infant up for adoption? Do they have identified family members? That population comes to us sometimes, they're unhoused prior to however they interacted with the
Okay.
psychiatric system. Um, and so they might not have family, but giving them the opportunity and the ability to engage and be a parent for those few moments.
Mm.
And also after they deliver, if they are stable at the time of delivery, giving them some time to engage in the capacity that they're able to
Mhm.
with the infant. We always consider the safety of the patient
Mhm.
and the newborn baby, but want to be able to also provide those meaningful moments of connection.
Mhm.
So if that woman is stable and from a psychiatric perspective, we've figured out medications that she can be on, that we really allow those moments of bonding to happen
Right.
at the time of delivery.
So naturally, you truly appreciate the importance of being compassionate to that group. In some ways, going the extra mile, because mental illness, maybe incarceration, pregnant, isolated, no support system around them, trapped. In order to provide them the best care, you're dealing with so many systems,
Many
the,
systems.
the legal system, the penal system. Society may look at that person different.
Yes.
Uh, and you just even prejudice and discrimination among the healthcare
Healthcare.
providers.
Yeah,
I mean, it's
definitely.
how do you educate them like this is a real person? There's going to be a child that's going to be coming. We want to not just give that mother the best experience in what is regarded as the most joyful time or close to a very joyful time, but we have a future person that we have to take care of, and the mother is going to be taking care of that person
Yeah.
often.
Off
How do
or
you how do
potentially.
you work through all that?
Yeah, I think this is one of the things that I love that really made me fall in love with this field is this
Mhm.
population. So this severely mentally ill patient population, like I said, they get pregnant.
Yeah.
And how do we navigate those
Well,
systems? And so the growth of this field is to help make that more
yeah.
successful. So really working with our colleagues to recognize what is schizophrenia or
Yeah.
what is schizoaffective
Hmm.
disorder. Understand that if I have that, if you who these other our
Yeah.
colleagues like OB-GYNs, if they identify and recognize that they have a very sick patient, to get us involved as early as possible
Mhm.
so I can help them treat that mother, get her stable, and help them feel more comfortable with the process of the end of pregnancy, giving birth, so they can feel more comfortable engaging. What's so important about that and getting reproductive
Mhm.
psychiatrists and reproductive um, psychiatric workers, so also
Yeah.
our therapist and our social worker counterparts, is so that we can help them plan. So
Right.
lots of like care team, interdisciplinary plan, meetings
Right.
with an interdisciplinary care team. So I can provide education for my colleagues who might be, if you get that patient admitted to your service, you're
Yeah.
like, I have
Oh,
a
yeah.
a schizophrenic
Yeah.
36-year-old,
Yeah.
39 weeks pregnant,
Right.
had limited prenatal care. You can see, and I can empathize with the OB-GYN
Yeah.
who's on call, like
Right.
their anxiety is
Yeah.
increasing. And so getting us involved, we are there to assist and
Yeah.
help that go smoothly.
Yeah.
and figure out
It
we
almost
have,
sounds like
yeah,
your job is to care for the team. Like
at times.
like
Yes.
an
Yeah.
OB-GYN doctor, the staff on the unit, just,
Yes.
you know, the how
Like, how do you make sure
they
the
yeah,
infant is safe?
right.
Do you need to get child
Yeah,
protective services involved? How
right.
do you do that? Where does the infant stay after
Yeah,
delivery? Navigating when that mom can visit. Does that baby
right.
room in with the mom, or does the
Yeah,
baby room in the nursery or in the neonatal
yeah,
ICU? There's a lot of decisions that can cause that care team just
yeah,
so much anxiety, and we are there to help, really give expert advice and opinion because we assess that mom and
right.
her capacity really at every moment of how safe she is to be involved.
So there's obviously so few of you for the number of people that could really use the service that you just described. You did say a little bit earlier, or the like advisory boards and organizations that you're developing. Are you feeling that the message is getting out? Because there'll never be enough
There'll never be
reproductive,
enough
yeah.
reproductive
But
psychiatrists. No.
the are is the training of the importance of what you do when you're actually involved getting disseminated to every corner of this country to some
I
degree?
think I mean I hope we are working
Yeah,
towards that. I would say there definitely needs to be done. I mean, my dream would be that every state would have a perinatal access
yeah,
line. So for both, there's the communities that have me,
yeah,
but those that don't, that are, in rural parts of states, that they could call somebody in this
yeah,
when a patient like the one I described
yeah,
presents to them, and they can have somebody walk them through the process. They won't alleviate all of the fears, anxieties, but it would be beneficial.
yeah. Um, you know, as putting all this together, and it's so important what you're doing. I as I've grown further in my career as a general adult psychiatrist, not a triple boarded person, uh, like health economics outcome. It's a word we often use, but when you talk to legislators and others about this is important, can you share with them, if you provide this, you're going to not only have a good outcome, but you're going to save money. Our
Oh yeah.
society is going to save, you know, millions and hundreds of millions. And are you getting skilled in hammering like those 2 points? Like
Those
you
two,
got to, this
we
needs
gotta do
support.
this.
Yeah,
I mean, I think that's what
yeah,
what
yeah.
this community of reproductive psychiatrists is
Okay.
really trying to do. But it goes back to even talking about those is I go back to kind of what drew me to this field
Yeah,
and what I describe when I mentor people. And what I say, what I do is I'm a reproductive psychiatrist, but I'm a penultimate child and adolescent
yeah.
psychiatrist, right? So, like, I am trying to help um, these families
Mhm.
start off in a healthier and more supported space so that from a money
Yeah.
saving perspective that these children grow up to be happy and healthy older children, teenagers, and adults themselves. And so it's really, yeah, it's an investment that pays off. If we invest in young parents, it will,
Yeah.
pay in dividends.
Yeah. And, maybe uh, as we come to a conclusion, there's two items. We've been talking about work and all. I'm really curious. You found the perfect fit, that 100-piece puzzle where you didn't
Took a long
it's
time.
not under the table. That where's that last piece? You found it at a young you at a young age. You
Thanks,
found it.
Rimal.
You really did. But do you what brings you joy outside of work? I mean, is that puzzle complete?
Complete. Yeah, that's a good.
Yeah.
So, music and my
Okay.
kids.
Okay.
Um, so I have two kids.
Yeah.
Uh, so and of course well, everybody's kids
Sure.
bring them joy.
Yeah.
And spending time with them, that's my
Uh-huh.
primary outside of work
Yeah.
joy.
Right.
But what I would say bonds my entire family is I am not a musician, but a passion for music.
Okay. Yeah.
Well, I'll joke with you. Well, I can tell you, tell everybody some funny
Yeah.
things. Um, so the whole reason why I tell people that my husband and I got married is we can blame it on Robert Smith and The Cure. So that's like music has been,
Yeah,
yes,
right.
it's a core,
Yeah.
uh, uh, yeah, part of our family. So
Okay.
I was teaching swim lessons.
Okay.
He was singing a Cure song.
Yeah.
This is back. It's going to be 1997 again, but I
Right.
was not starting the
See,
women's mental
yeah.
health division at UIC at that time. But anyway, he was singing
Yeah.
like you could probably call it like a B-side from a
Yeah.
Cure album, and I
And
recognized the song.
right.
Anyway,
And you can picture that day and that
oh yes,
music. It's,
I
in
joke
essence, it's
that's a
imprinted.
funny meet cute
Yeah.
or
That's wonderful.
anyway,
So,
but music has been
yeah.
in our when it was just the two of us, a really
Yeah.
important part of our life,
Yeah.
and then still with my kids. And so both my kids are now dancers and love
Right.
music. So
Yeah. Well, this was wonderful. I mean, this ending, I clearly, your work probably fuels your joy of home,
yes,
and the joy of home fuels I mean, that's, maybe you,
synergy.
yeah, maybe you
Hopefully,
will do a 1,000-piece
it's
puzzle.
like you can
There's
ask my
no,
kids
yeah,
if that's true.
right, right. Well, they'll say no or yes, but they know. I got a good sense of the importance of the work. For others that want to know more about the organization that you're involved in, uh, people that are entering mental health and want to, be informed, the general public, how would they, where would they go to learn a little bit more?
Yeah, so to really for those that are interested in just the whole field of reproductive psychiatry, there's several organizations. Like I've already mentioned, Postpartum Support
Right.
International. That really focuses, obviously, based on the name, on that perinatal period. There's the Marseille Society of North America. But there's also the International Association of Premenstrual Disorders, and that organization focuses on the non-pregnancy related hormonal shifts
Okay.
that can affect mood and anxiety.
Would these be organizations just for professionals or the lay public?
Both.
They
So they
could,
have
yeah,
lots of information on their
okay,
websites. The International Association for Premenstrual Disorders really has a wonderful public patient
right,
facing, like where do you seek care? Who are the other reproductive psychiatrists
okay,
that are either in your country? It is international, so it's not
okay,
just restricted to the United States. And the same thing with Postpartum Support
okay.
International.
And is this information getting to like the high school level? Because every high school has like an assembly on
Yeah.
pregnancy and uh, you know, uh, safe sex and all. Are there elements getting to that level?
I know based on just from like the patient
Yeah.
referrals that I get that premenstrual women that
Mm,
suffer from premenstrual dysphoric disorders that there seems to have some trickle down
trickle down. Okay.
where adolescents that are suffering do get attention,
Yeah.
but we could always do more
Sure.
work um, to get the message out that it's
Right.
safe to you know to
Good.
to look into this,
Yeah.
to ask for help.
Okay. Excellent. Thank you.